Hello, I'm Dr. Mark Kunick. I'm a geriatric psychiatrist at the Houston VA, the Michael E. DeBakey VAMC, and Baylor College of Medicine. Today we'll be discussing late life depression, Part 1, Screening and Diagnosis. The content is brought to you by the Southeast Texas Geriatric Workforce Enhancement Program, which is a collaborative program between Baylor College of Medicine and the Michael E. DeBakey Veterans Administration Medical Center, in partnership with other academic and community service organizations. The project is one of a network of 48 nationwide WEPs, supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Together, we aim to improve health outcomes for older adults by developing a healthcare workforce that maximizes patient and family engagement by integrating geriatrics and primary care along with the 4Ms framework to create age-friendly healthcare systems. So let's get started with screening and diagnosis. We'll start with screening. I'm going to talk about 4 screening tools that may be a help depending on which practice setting that you're in and your office flow. One of these may fit your practice better. Please note that you can get copies of all of these and much more tools on depression screening and diagnosis in our toolkit. So please go to our toolkit and check out the information there. We'll start off with the PHQ, the Patient Healthcare Questionnaire 2, which is the easiest and the shortest of these 4 screening instruments. It essentially has the first 2 questions of DSM-5 on them. Over the past 2 weeks, have you been bothered by any of the following problems? Little interest or pleasure in doing things, or feeling down, depressed, or hopeless? And it's scored on a Likert scale, as you can see here. This can take as little as a minute or 2 to deliver in your office. It's a good screening questionnaire, but it's really too short to measure whether there's changes over time. The PHQ-9 version, the Patient Health Questionnaire 9, is a full-length patient health questionnaire and has the 9 questions that are essentially the questions in DSM-5. And again, these are also scored on a Likert scale. This, on the other hand, can be used for screening and also can be used to measure a patient's response to treatment. So that's an advantage of this scale. And both of these scales have been validated in younger and older adults. The Geriatric Depression Scale is a scale that was validated particularly for older adults. And some of the differences that I would highlight in this scale is, one is it's a yes/no. So the patients don't have to go through a Likert scale. So it requires a little bit less literacy than the PHQ-2 or the PHQ-9, and can be used for persons that have mild cognitive impairment. And the Geriatric Depression Scale was created with knowing that geriatric patients often have especially those that have physical medical disorders, have overlapping symptoms of depression that are part of their medical illness, like sleep problems or appetite problems. And so this scale has less of the somatic symptoms and more of the psychological symptoms of depression and more of the cognitive symptoms. So for example, do Do you feel that your life is empty, or do you often get bored? How are you in good spirits most of the time? And so this one also, has the scoring as below. And again, you can get copies of this in the toolbox. And the last one that I want to go over is the Cornell scale for depression and dementia. This one is designed as expected for older persons that have dementia, and you want to screen for depression in those patients. This one is a little bit more difficult to use in that this one is not. This one is it has to be administered by a staff member, and it's a little bit longer as well. But if your practice has if you're having a practice or a clinic that's predominantly persons with dementia or cognitive impairment, this may be a scale that you'd like to use. All of these scales have been validated in older adults and have decent sensitivity and specificity. Like I said, previously, the PHQ-9 is a one that and the geriatric depression scale are probably the ones that are best used, if not only for screening but looking at response to treatment. So I suggest that you look over these two, try them both out if you haven't used them, and find the one that you think fits your practice best. So now let's talk about diagnosis. The diagnosis of geriatric depression is this. We use the same diagnostic criteria. So I'm going to summarize the DSM-5 criteria and then talk about some of the differences in how older adults present. So the criteria for major depressive disorder require 5 out of the 9 symptoms being present, and including one of the first 2 being present. The first 2 symptoms are the ones that I mentioned in the PHQ-9, feeling depressed or markedly diminished interest or pleasure in activities. And I think as you read through this, and this is important when you assess for the diagnosis of depression, they have to be, these symptoms need to be present 2 weeks, and also that they're present nearly every day and most of the day. So if somebody has these, a couple days a week, that's not going to meet the criteria. It really needs to be nearly every day and most of the day. The symptoms need to meet the criteria for depression. They need to cause some significant distress or impairment in a person's life, and they can't be directly attributable to a substance use or a medical condition. So geriatric depression, about 20 to 30% of the time, is accompanied by psychotic features. These are usually features that are mood congruent, that go along with the depressive illness. For example, hearing voices of somebody saying that you're a bad person or that you don't deserve to live anymore. Psychotic depression occurs in those that have more severe depressive symptomatologies and has a worse prognosis, a little bit more difficult, more resistant to treatment than non-psychotic depression. Interestingly, for the treatments of psychotic depression, it doesn't appear that adding antipsychotic medication confers any more benefit than using the antidepressant medication alone. We'll talk a little bit more about that in the management section, part 2. Diagnosis of depression is different in older adults and younger adults in that older adults are less likely to say that they're depressed, even when directly asked, but more likely to say that they are in pain, or that they don't have much energy, or they're having problems sleeping, or they're constipated. You get a lot more of the somatic symptoms. Also, depression is harder to diagnose in older adults because so many of the physical medical disorders have overlap. Their symptoms overlap with depressive symptoms. Symptoms such as fatigue, decreased energy, decreased appetite, and decreased sleep, which are common in older adults with multiple morbidities. So with that, I will bring this, to an end. So I hope this presentation gave you some useful choices in screening measures, and that it gave you kind of a summary of diagnosis of depression, and particularly depression in older adults. So thank you for joining us today for screening and depression in late life depression. That's part 1. We will have part 2, so please look for part 2, which is management of late life depression. We understand that your time is valuable and appreciate your commitment to providing age-friendly care for older adults.